Okay, well, we can get started. Welcome to the 26th Community Advisory Group meeting for Alameda County. Alameda County. Wanted to welcome you here and announce that we have live interpretation in Spanish. So if you would select the globe with your language of English or Spanish, we would appreciate you joining us that way. So maybe if someone could repeat that or paraphrase that in Spanish, please.
Hola, ¿qué tal? Buenas tardes. Bienvenidos a otra junta de la Agencia de Servicios de Cuidado de Salud del Condado de Alameda. Por favor, para todas aquellas personas que necesiten interpretación en español, hagan un clic en el globito que aparece en su pantalla en la parte baja y seleccione, por favor, la opción de español. Muy amables. Gracias.
Thank you. I will start now. Next, we have closed captioning. So you can select viewing full transcript if you want to follow along that way. And we also, if persons using captioning want a separate captioning window, then we'll drop that link into the chat for you to use. Reminder to speak slowly for our interpreters and captioners. And we're also live on YouTube. And I would love to pass things over to one of our co-chairs, Greg Hodge.
Hey, good evening, everybody. It's good to see you all. Hope you're having a great day. On behalf of myself and Nestor Castillo and Kimmy, I want to welcome you to this meeting. It's an important set of conversations that we always try to have to bring us up to speed on where things are with the pandemic and now with monkeypox and a range of things, as well as our strategic refresh. But as we do that, we want to acknowledge all of our ancestors, particularly the Ohlone people, the Native folks who were here before most of the rest of our ancestors got here, and thank them for allowing us to be on their land, in their space. And I also want to just take a moment to acknowledge someone who was an Oaklander, made a mark for himself in the sports world, but also as a civil rights activist, Bill Russell. Some of you know Bill Russell passed away this week at the age of 88. He was a McClymonds High School graduate, USF Dons, 11-time NBA champion with the Boston Celtics, and probably one of the most celebrated athletes of any sport anywhere. But he grew up in West Oakland. I happen to live in West Oakland, and we're proud of his legacy. And it always is just a fun fact to me that when Bill Russell was in high school, he came off the bench. So I always wondered, like, who else was playing? Jesus. But he distinguished himself as a voice for fairness and civil rights based on his experiences in Boston, which at that time was a very racist environment for him to be in. But he was always someone who stood up for his community, stood up for humanity. And so we're just going to acknowledge Bill Russell's passing in this moment. So as always, we want to hear from our partners and hear some updates and lessons from the field. So we'll just open this up to anybody who's got something you want to share in terms of what's happening out in the community with response to where we are with COVID and the various variants, as well as monkeypox, anything else. So anybody from our community partners, community clinicians, and others who want to add something to where you think things are. Anybody? All right, that must be a first. Oh, there we go.
Sorry, I came in a little late, not early.
Okay.
When you say where we think themes are, what do you mean by that?
Well, updates from your work, where things are in terms of keeping folks safe in this round of the pandemic. Anything else you want to share by way of update?
Got it. Okay. You know, I think right now we're definitely in an in-between stage. There's a lot of conversation in regards to is it over? Is it not over? Do we need to get vaccinated? Do we not need to get vaccinated? And I think it's just been a lot of overload. So I know we've talked about exhaustion, but I think it's led to more confusion at this point. And I think we kind of need to do a little bit of recharging the batteries with the community in a way that we can let people know, hey, where things are at now. This is where we're at. This is coming from, public health or community partners in partnership, if you will. And maybe doing something like that, maybe a few town halls is what I would suggest. That's one thing that I would do. I think that the other caveat would be, I do want to thank public health. I want to thank, Dr. Yala. I want to thank Sandy. I want to thank Vasi. It's been a whirlwind. It's been difficult. I know we have to do a little bit of advocacy, but there continues to be a lot of support there. And just want to say thank you to all the public health staff. If I missed anybody, Kimmy or anybody, my apologies. But just wanted to acknowledge that. I think that too, where we're at is that we really need to look at funding past ARPA, because this isn't going away. I think when you look at it from a monetary perspective, I know any CFO would say, hey, well, the money runs out, the program runs out, and that's it, right? But the issue's still there. And kind of like HIV and AIDS, there needs to be a department there within, I'm talking about CDPH. I'm not even talking about at the county level, but a department there that can fund our public health department as well. But it needs to come from the state and the feds. And there needs to be that conversation about long-term funding. Maybe it's less, but at least we know it's going to be continuous, and it's going to be there to deal with the ups and downs. And that's something that we should have discussion now, because when the ARPA money is gone, I don't want the discussion to be, hey, you're done, that's it. Especially if these variants are still persisting, and now we're dealing with monkeypox as well. So that's one thing that I would say is not above, not beyond, but right after, it needs to have in a kick shift that can carry on the support. So that's a dialogue that I think we should all have. It's not just on public health, it's on all of us.
Aaron, thank you for that. Any other updates? And Aaron, you actually prompted me to sort of think a little bit about what's happening with schools, given that schools are just opening back up. And I know there have been a range of concerns there along the way this past 2 years. But anybody, any other updates before we hear from our county folks?
Pastor Arlene has her hand up.
Oh, thank you. Hi, Pastor Arlene, how are you?
Hey, I'm good, thanks. My hands look a lot like the color of the paint in the sanctuary. Well, we're blessed. We're also challenged. Almost from the get-go, I was pretty sure that the pandemic was going to be as much of an economic crisis for us as it was a public health crisis. And, I hate it when I'm right. I was right about that. And, I think, I agree with the things that Aaron was saying, about, people, maybe just getting kind of dull to the, the relentlessness of the public health crisis, some confusion and some anxiety about the, vaccines and go back to school and, in person, and are the kids safe and all that kind of stuff, but the even, I guess, louder sounds and angst that is really clear to me from here in the unincorporated communities is the economic concerns. When we entered into the shelter in place and all that kind of thing, there weren't that many families that had 2 months rent in the mattress. And so people were very quickly in crisis and so forth. We're exceeding our peak, in terms of participation in our food pantry. That's a pretty good barometer of how things are going around here. And within 2 weeks of the pandemic shutdown and everything, we had 5 times more customers than we'd ever seen at our food pantry. And we are now exceeding those numbers. So, you know, for some people, woohoo, you know, they're going to Paris, they're having a great time, they're taking cruises, right? And not here in Chairland, here in the unincorporated communities. And, you know, when I listen, I sit in on conversations about the housing ordinances and things like that. I mean, the level of stress among our families, you know, and also small landlords, a lot of small landlords, you know, the stress that folks are under is palpable.
Yeah.
And, you know, we need 2 kinds of cures. And,
Yeah.
you know, and, you know, that's another way of saying what's beyond ARPA, right? Because there are some people, and especially in the unincorporated communities, that will not recover in 2 months or a year financially from these things. And I think especially adults with, you know, fragile immune systems or other kinds of challenges in terms of their health and their ability to work. I think about young parents, 2-parent families where one is, you know, both were making minimum wage, but now one just can't dare leave the kids. And then there's the single parent family, and then there's the single parent family who are newcomers. And then there's the single parent, or then there's the single teenager with no parents. You know, for those populations that I'm describing, you know, it's going to be a long way back to go. And I think people on this call know that, but not everybody does.
Yeah.
So anyway, we aren't giving up. But, you know, we almost had to close our food pantry because there's a 12-month gap in funding for emergency food services. You know.
Yeah. No, well, Pastor Arlene, thank you for the reminder, because I think you're right. Most people know, but I think what we're all up against is a bit of complacency, thinking that we're past the worst, and you know that makes people kind of let their guards down, and the fatigue. But the fatigue does not tell. COVID doesn't believe in fatigue, and neither does the bills that are coming in, or do the bills that are coming in. And I just think that you know, we've been saying this to our county leadership at the board supervisor level. Like, whatever resources you have, you need to get them on the street. We've been saying this for a minute, and I know other people have too. And I know everybody on this call, nobody has control over any of that. But it's got to be. I mean, every time I talk about it with somebody, and that we're sitting on a $2 billion reserve in the county, and people are hungry, it doesn't work for me personally. But thank you for that. Thank you for the heads up on that. And Gary Bliger just mentioned too the mental health issues. We just some of us may have seen this new study that's come out, and just how hard the mental health stuff has been, particularly with our preteens, and particularly with preteen girls. Like the 12, 13, 14, 15-year-olds are having a really hard time. And this is all over the country. So we still got a lot of work to do. Anybody else by way of an update from your side of the community?
This is Tao from the Regional Pacific Islander Task Force. Hi, Mr. Hodge.
Hi, Tao. How are you?
Hi, everyone. I know I've been MIA for a while here, but you know, like me, the COVID fatigue. And then by the time 5:30 comes in, since 8 o'clock in the morning Zoom, I'm zoomed out, and so does my internet. So
yeah,
I want to come from a place where you heard that term, we're always behind the 8 ball. So our systems and our processes when it comes to small population like Pacific Islander, and the way these funding are being distributed and funded, I have to say that we have been very fortunate to be among just the greatest, you know, people that makes up these coalition. And, you know, I see Pastor Arlene and Brother Aaron and all of us. These are champions and soldiers on the ground. And so coming from a very, very small population and being, you know, and being asked, hey, come join us, be part of our coalition in the unincorporated and South Hayward. Then on top of that, we have processes that, on top of not being able to qualify for receiving funding on a county level, but what we're asked to meet, like in zip codes and all of these different goals and processes, it kind of makes it even more harder. And we've been asking for a lot of this back in 2021. And finally, we have funding. There was delayed in the processes, but when we did get it, we're left to have to, jump more barriers and hoops to meet the requirement. And I have voiced this. I'm coming back now because you want to know what's happening on the field. We are definitely COVID fatigue. The community is tired of hearing there's a inconsistency. We've heard it all, but we are trying so hard to say we still have a lot of our Pacific Islander not vaccinated. And our coalitions are so awesome. They hear that, and we're all helping these zip codes that you all gave us that we have to meet. But on top of it, none of those zip codes fit our Pacific Islanders, but that's okay. We have to help everyone. And we're trying to fit things in a hole where we don't fit. And so if we continue doing this, we're going to have more people dying because of whatever it is. There's no finger pointing here. Mr. Hodge, you need to hear that now the church that we are utilizing has sold, and we have to find a home for us to do. And with all the coalition help, we finally had, have dates for vaccination and testing for the whole year. And then all of a sudden we hear the church is sold to a school. And so we don't know where our service is going to be, but that's besides the point. But this is the reality we're dealing with. And then we have to remember all of these things that you want us to do. And this is only Alameda County. We have to deal with all the 10 counties in the Bay Area. But I know I'm taking up time, but I'm being very, I'm adamant about, I know we're all working so hard for this, but I think we need to be, I don't know how many spaces we have to sit in, but being methodical and being strategic and being mindful of all of us that are in this space. We need to do something different. I don't know the answers to that, but we can't keep going and spending money, but we're like behind the 8 ball already. By the time we bring money to spend, it's too late. The train left the station, folks. And I don't know how to keep saying this. I speak Samoan, but it's not gonna get anywhere. But my heart is with all of you and with myself. It's my health, too, but but I'm strong and my will is strong. So I thank you for everything and creating this space, to all of you, because I feel you. But for me, we're pushing Boulder up the hill here in trying to reach Pacific Islanders. And a lot of us have preconditioned issues as well. And so chronic disease is on the rise. And when we talk about response to recovery, that's where the conversation needs to constantly be in, because communities doesn't know how to do that. And they don't understand what that means in public health terms. So maybe we can be a little bit more easy on the, trying to speak the language of all communities. So sorry for sound rambling on, but that's okay. It. That's what it is. Sorry, guys. Thank you so much.
Tao, thank you so much. And thank you for sharing where you are, and especially around, the space need. And maybe there's somebody on this call who has some ideas. If you have some ideas in the chat, in terms of a space for the community that's had this building sort of sold out from under you. And thank you again for sharing your heart in this. We know you're working hard at it. We got to make our systems, all of our systems, work better for folks who are the most vulnerable. Gary, you get the last comment on this before we go to our county folks. Go ahead. Good to see you, Gary.
It's good to see you also, Baba. Yeah, so definitely in sympathy and with regards to the building and connection with regards to the solidarity of community engagement. Have been mentioning this for a long time, that from a messaging standpoint, community navigators across the county need to have singular voice, need to have singular message, and that we engage in the advocacy of all communities. And by doing so, we impact particular communities, such as the Pacific Islanders, African Americans, Latinos, all communities, you know, but there's a singular voice, right, that is utilized as an entity to message to the public health department, to the board of supervisors, from the community, literally from the community, right? And then vice versa. We now are under, you know, dual pandemics, you know, just having come out of the street, people are hurting in every aspect of the term hurt, right? Economically, emotionally, you know, psychologically, they're, you know, financially, it's just rampant. And see, the irony of it is that none of this is new. We knew, I mean, the pandemic just exacerbated it, but we have been aware of the conditions of the communities for a long time, regarding housing, regarding food disparities, you know, chronic diseases, right? And so we have the attention of the community, we have the attention of the public health department, also the supervisors, etc. And the messaging, even with regards to the processing of grants and applications, and that, you know, needs to be simplified, that there is an ease of engagement that allows the full might of the community to be, you know, addressed. And so my concern wholeheartedly is that we talk about other chronic diseases. I mean, our team, we talk about, you know, diabetes, we talk about cancer. You know, when we're in the community, we give out PPEs, we talk about COVID. We're now starting to talk about monkeypox. And now they're thirsty for information, right? Hey, my uncle has this disease. My aunt has, you know. And so the wide array of messaging from a unified voice across all of the county by community navigators who are in the streets, trusted messengers, is the ideal platform. Mentioned it before, there is our efforts underway that we've sent the introduction to Dr. Moss, Dr. Ayala. I had been in anticipation of speaking with you, but I had to go back to the group before I could address yourselves, because if there was no unification there, and that the messaging was as one, the idea was as one, then we could not come to you and be, you know, segmented. Again, I do believe that is the method by which we can best impact our community, by addressing multiple concerns and healing the community, but then also hearing the community, right? It is well past time that the message come from the people, you know, to the powers that be, whomever that might be, public health, supervisors, you name it, right? The governor. And the model that could be utilized in this regard could sweep across the state, all 58 counties, could sweep across the country. It is valuable that we start addressing the multiple chronic diseases and concerns that are in the community. I'm complete.
Gary, thank you so much for that. You're absolutely right. And I appreciate your consistency and resilience around that comment has been a consistent one. I think we're going to move now to hearing some updates from our county clinicians, Dr. Moss and Dr. Dunn, and Nestor is going to facilitate the conversation from there. So Dr. Moss, Dr. Dunn.
Dr. Moss, are you muted? I think you're first.
Yes, if maybe Dr. Dunn could go first. I'm transitioning from BART to bus right now. Would help.
Sure thing. Dr. Dunn, are you available to go?
Yeah, happy to. Hi, everybody. Nice to meet you. My name is Eileen Dunn, Dr. Dunn. I'm new to Alameda County Public Health Department. I'm looking forward to working with you. I'm going to provide an update on the monkeypox outbreak. Next slide, please. So what is monkeypox? Monkeypox is a rare disease caused by infection with the monkeypox virus. And this virus is a relative to the virus that causes smallpox, but the infection is not as severe as smallpox. The monkeypox infection can start with flu-like symptoms, and those are can be typically fevers or chills, headache, muscle ache, backache, swollen lymph nodes, and fatigue. And then a skin rash can develop a few days later that can be located anywhere on the body. But for this particular outbreak, this rash has been commonly located in what are called mucosal areas. So that's the mouth, the genitals, and around the anus. Sometimes the illness can just be the rash. The rash is often a red and bumpy rash that is umbilicated, meaning that it has a dome with a sunken center. It can have blisters or pustules, and then it can progress to scabbing. Many patients report that the rash can be painful or itchy. Next slide. So it's important to note that any person of any gender or sexual orientation who has close or intimate contact with an infected person can get monkeypox. It's primarily transmitted in the following ways, which includes direct skin contact with the skin rash, the scabs or body fluids of an infected person, intimate contact, including kissing, hugging, sex with an infected person, sharing unwashed bedding, towels, and clothing with an infected person, and prolonged face-to-face or close interactions that can occur usually in a household or living situation when someone shares a room or space. Next slide. In Alameda County, as of the 8th of August, there have been 106 people with monkeypox that have tested either confirmed with monkeypox or probable monkeypox. Monkeypox infections are occurring mostly among persons who are aged 31 to 40 years of age, who are cisgender men, men who identify as men, and transgender people, and gay men and other men who have sex with men, as well as bisexual men. The predominant race ethnicity has been 47% of Hispanic and Latinx populations are cases. Next slide, please. So what are some of the public health priorities at this stage in the outbreak? A really important one is collaborating with our community and healthcare partners on the public health response. We're reaching to identify monkeypox cases and close contacts of cases. And this is primarily occurring through testing of rashes. There's contact tracing occurring for all cases. Specifically, that's identifying close contacts that could benefit from vaccination. We're providing guidance and support for isolation for those who are either suspect or confirmed to have infection. And as suggested in the earlier bullet, vaccination of close contacts of suspect and confirmed cases. We're also working for accessible guidance on testing, isolation, and vaccination, as well as treatment. We are actively looking for treatment settings in Alameda County that can support treatment referrals, especially for the most severe cases. And then our county is allocating, providing vaccine and helping with vaccine administration questions to county residents at risk. And that's specifically, we're helping with guidance for vaccination, allocating vaccine to community clinics, vaccine pods, and healthcare settings. We're also helping with infection control guidance for healthcare facilities, workplaces, and congregate settings and other settings. Next slide, please. So what can county residents do? Anyone with a history of flu-like symptoms and rash or rash alone that is characteristic of monkeypox should consult a primary care provider and get tested. Persons with this new rash should isolate. That means remain alone at home and contact the provider. And persons with close contacts, persons who with a close contact with someone who is suspected or confirmed to have monkeypox should get vaccinated within 14 days. And we're trying hard to reach within 4 days. Healthcare settings and community vaccine pods have vaccine available for those at risk for monkeypox. And for those that have do not have a medical home or are not insured, we're working closely to get those folks tested in settings throughout Alameda County. Next slide. So some questions that I think were brought up by you is questions about the difference of monkeypox compared with COVID. And I wanted to just highlight some important attributes of monkeypox. Monkeypox is primarily an illness related to close contact with someone with the virus. Most persons with infection have had the characteristic rash, and most persons with infection have had close and intimate skin-to-skin contact with someone with a rash or someone likely to have had illness. Some persons with infection have reported that they have shared linens, towels, or being within a household with someone with a rash. Very rarely, respiratory transmission has been reported, and this has primarily occurred in settings in which there was also close contact. And there is no evidence to date of asymptomatic transmission of monkeypox. Next slide. So I think there's a lots of opportunities and lessons learned through COVID, throughout the COVID response of some of the importance for the monkeypox response, and primarily is working closely with community partners such as yourself. And I appreciated the highlight of the trusted messenger, that the community partners are the trusted messenger for this response as well as the COVID response. I think through the COVID response efforts, there's been expertise that has developed through community partners and through others. And those similar expertise is really needed in the monkeypox response as well. For example, community vaccination pods are needed for the efforts in monkeypox response and guidance that serves communities' needs. We're also working to have accessible and appropriate languages for all the guidance, and we're prioritizing communities with disproportionate impact. Next slide, please. So one question that arose from community partners was, who are we trying to reach with our monkeypox response? And so the primary reach is to all of the community, but especially to gay men and other men who have sex with men, Hispanic, Latinx, and Black and Brown communities, challenged communities, specifically those in the HPI quartile 1 and 2, congregate settings that have specific needs for infection control, and healthcare facilities and providers. Next slide, please. So actually, I'm happy to take any questions that you might have around the monkeypox response.
Any questions for Dr. Dunn?
Dr. Dunn, good to meet you. Thank you for sharing information with us today. Pleasure. How's the process to get tested?
Yeah, that's a great question. So many settings, emergency rooms, clinics, and community clinics are implementing testing protocols. The testing is essentially a swab that is rubbed on the rash, usually open sores, blisters, or pustules, usually more than one sore from the rash. It's put into a container and sent to the lab. There's two types of labs that are doing testing, commercial labs. There are a number of commercial labs that are doing testing right now, including LabCorp, Quest, and others. There's another pathway for testing. It's through the state lab. And Alameda County Public Health Department is facilitating testing through the state lab when that is needed. I hope that answered your question.
Oh, thank you, Dunn. Dr. Dunn, and in addition to that, thank you for the partnership. And Familia looks forward to rolling out the monkeypox vaccine at the end of this week or next week, from what I understand from our team. So we'll be providing that out of our SkyWest site soon. So thank you.
Thank you.
We have a question from in the chat, and it says, do we know what is the primary language among those that are infected who are Latinos? And then a hand from Gary Blodger.
That's a great question. My assumption is Spanish, but there could be a variety of other languages also. And we're definitely prioritizing our guidance documents in Spanish, as well as website and other types of information.
Gary?
Thank you. Yes, thank you, Doctor, for your presentation and your presence. I want to ask, with regards to the collection of data and testing, what processes do we have in place where, just as with COVID, are we collecting that data? Is it regional? Is it statewide? Is it national or international? Right, so that we can perhaps determine a trend. Also, secondarily, are there discussions around the implementation of home tests? Because if there is the ability to capture this in this early, introduction to individuals, how can they, similar to as we do with COVID, is there a monkeypox home test that can give individuals the capacity to know that they are infected and seek treatment at an early stage?
Those are great questions. Thank you. The first test about testing and tracking of test results. And so any test that is positive is in an electronic system in California that is being tracked on. So the number of tests done, as well as the results of those tests, the type of test done is followed over time. And that's also occurring at a national level as well as a global level. So this is a global outbreak. And so those types of testing is also being tracked as well around the world. And I really appreciate your question about home testing. And I think testing right now is only one pathway. It's testing of the rash. However, there is development of new testing platforms and testing methods that would be much more accessible for communities. Home testing isn't available yet, but there are different tests in development. For example, tests to look at the immune response to infection or other types of tests that might be more accessible. So I really appreciate that question, and I'm hopeful for new and different testing pathways.
Yeah, I'm sorry, if I could just follow up quickly. Are they testing wastewater?
Yeah, that's another good question, Gary. Thank you for that. Wastewater in parts of the Bay Area is being evaluated for the monkeypox virus, so that there is detection of, whenever there's cases in the community, there can be detection in wastewater as well. So in various communities throughout the Bay Area, as well as other parts of the country, there is evaluation for the monkeypox virus in wastewater.
Dr. Rhodes. Oh, there you go.
I had a question about I thought I heard Aaron say that La Familia is going to get vaccine, and I know that vaccine is in relatively short supply, just in general, in terms of production in the country. And so I'm just wondering, how are you deciding how many doses you're distributing through some of the community sites that really, through the course of the pandemic, have really shown can reach some communities that would otherwise not be reached? And obviously I'm asking because Umoja is one of those groups. So what is the process for getting vaccine as a small allocation for our different sites?
Yeah, no, that's a great question. And I'm glad you highlighted that we are experiencing shortages in the vaccine, but we are reaching to many different healthcare and community groups for interest and capacity to vaccinate, because I think the broader our efforts and also reaching to challenged communities, the better. So I think if your community, your setting is interested in vaccine, we would be eager to hear from you about your ability to vaccinate, especially those that we're focusing on, which is post-exposure prophylaxis, those that have been exposed or potentially exposed to monkeypox. So I would welcome that conversation.
So is that an email to you, or does that go through Healthcare Services Agency? Like, who is kind of controlling the distribution of the small allocation that we have?
Yeah, so I think you can reach to our website, Monkeypox. Someone can put it on the chat for me. Thank you. I haven't memorized it yet. I probably should. But yes, you can reach to that. And what we're doing is we do an engagement activity where we have a conversation and we understand a little bit about capacity, who you're reaching. Of course, we really feel like the most important aspects is reaching to the communities that need to be served for this vaccine. And so that's also an important part of the conversation as well. So I think, Nitu, thank you, Nitu.
For the sake of time, Dr. Dunn, is it okay if folks reach out through this website and through this email with any additional questions? Excellent. So now we will kick it over to Dr. Moss. Dr. Moss, are you ready to go?
I am. And thanks, Dr. Dunn, for jumping in. This should be fairly quick. Apologies for the disruption. I'm trying a new commute out and haven't mastered it yet. So in brief, this is a COVID case rate going back to late April. You can see that we have been at a fairly sustained high level of transmission going back to May and really increasing throughout April before that. And of course, this doesn't capture all of the infections in Alameda County or even home testing. We know testing rates change during this time frame, but nevertheless, the take-home message is a very long period of pretty sustained high levels of transmission. Now, the last couple weeks, we have seen some easing, still at high levels, but certainly better. And we do have some other indicators that corroborate this. So next slide, please. So I think this is really the most important one. This is East Bay Mud wastewater data looking for COVID. I did post the monkeypox data in the chat during Dr. Dunn's presentation. And you can see we have several weeks of data showing improvements. I'm trying not to celebrate the latest data point too much, that big steep drop. We've been burned before, but nevertheless, this is good news. I think after what has been really a pretty long wave. Next slide, please. These are daily reported hospitalizations going back to late April. We didn't really see hospitalizations tick up until May, and then they increased quite steadily until really last week. We reached a peak of just about 200 people hospitalized with COVID infection last week. We're down about 25% from that time. The state estimates about half of people hospitalized with COVID right now are there because of the COVID infection. About half are there for other reasons. We don't have that breakdown for Alameda County for this data right now, although we're hoping to be able to sort of look back at this wave and try to get at that question. The other thing to point out here is intensive care unit hospitalizations in yellow at the bottom never really exceeded 25 people in the ICU at any given time. So this is a lot lower than we saw during prior waves. That's good news, although of course, with the long duration of this wave, you do have to factor that in, and we know that there had been costs in terms of severe illness with this wave. And I think that is my last data slide. Next slide, please. Let's see. Yes. Any questions for me?
I think we have time for at least one question before we move on to the next item. If anyone has a question.
And I'm sorry, I may have missed it. Maybe I got distracted or something. I didn't see it. What is the actual number of cases of monkeypox in Alameda County?
Well, that was 106, Greg,
Okay,
from my notes.
thank you.
Any questions for Dr. Moss?
Gary? Anything? I'm teasing.
Always. How are you, sir? And compliments on your transportation choices for today. And hopefully they work out well for you. First, I'd like to thank you for, I believe, the August 15th date, if I'm not mistaken, with regards to acceptance of the community navigator invitation. We definitely want to continue building relationship and then expand that relationship in terms of bettering our process of messaging, and then also allowing it to be unilaterally two-way. Again, we thank you just wholeheartedly for your continued involvement and your information that is we're disseminating to the community. But we want to we really want to define a path by which we can bring community concerns to you that we can address in the moment. And that is other than COVID, other than monkeypox, other than, so we definitely appreciate your response. Looking forward to it.
Thanks, Gary.
Thank you, sir.
More supportive than some of the comments I heard at Board of Supervisors today. So, not from the board members, public comment. Thanks.
Okay, so I'm gonna kick it over to Julie Williamson, who I know is really excited to report back on how our strategic refresh is going. Julie?
Okay, thank you, Nestor, and good evening, everyone. Really pleased to be here, and thank you for your time on this. Let's jump to the next slide. Just a quick reminder, the process that we are in is we started back in June. There we go. Actually, we started in May to look at our strategic plan. At that time, Alameda County had a 2-year strategic plan on how to address COVID. And we are at the point where we need to update it. We're right at the end of that 2-year period. And we've decided to do a 1-year strategic plan just because COVID keeps sort of knocking curveballs at us. And so we thought, okay, let's shorten our timeline right now. So where we are last month, we captured your thoughts and ideas on 3 core areas of our response to the COVID pandemic that we felt that we could operationalize the things that you told us. So we wanted to really hone in on the areas where we could do something about your feedback and your recommendations. So what we've done is we took your feedback and we vetted that. We went to our the main units within the COVID division, and those were our testing units, our community vaccine unit, and then our COVID investigation and community support units. They've each looked at your responses. Remember the Jamboards, we broke into groups. They went through a process of pulling those together, identifying what the core themes are, and then looking at what our strategies are moving forward. So I'm hoping in the next 30 to 40 minutes, we want to, we're going to go through each of those sections just to show, you know, what you said, what we heard. And what I'd really like to hear from you after each of these presenters, we have the leaders from each of our teams here in the meeting tonight to let you know sort of what they heard and to describe a little bit what we're doing moving forward. And I'd really like to hear your feedback as they're talking about each of the strategies, to be thinking, A, do we capture your comments and your feedback correctly? This is really important to us, that we get at least the highlights and get the priority comments. And then we'd love to get your feedback on the strategies. Are there areas where we might have missed the boat or where we're missing something really important? Please let us know. So with that, why don't we just go ahead and jump in, and I want to turn it over to Vasi Kapila, who is heading up our testing team. And we're going to start with testing. We can skip that slide. We're a little short on time. There we go. So
good evening,
Vasi.
everybody. Great to be with you, and great to see so many old friends and comrades. I am going to be brief because this has been such a rich discussion, and I also have a toddler walking in the door in about 10 minutes. And if you think the Board of Supervisors are a unruly crowd, then you haven't met my toddler yet. So I'm going to just give, this is some of your all's feedback, and I'm just going to do a really quick summary of this so you can get reacquainted with it. Just some of the highlights around home testing access. It seemed that there were some comments that improvements had happened in terms of OTC kit access. In regards to challenges to home testing, degrading of data, which we're certainly looking at where we can fill those gaps to the extent that we can. Concerns about whether people have enough instruction available to them for using the test properly, and of course language access, which is an ongoing challenge that we keep working on. In regards to barriers to getting a test, transportation, dependent care needs, and enrollment in testing through technical barriers. And I'll just say about that, you know, one of our main strategies, I mean, these are actually some of the ways that what we'll address is kind of some of the latest ways that we are strategizing, but our overall strategy has been to support those most vulnerable, the uninsured, the underinsured, as well as ensuring those communities that have been most impacted by COVID-19 have low barrier access to testing. So that is the overall strategy. In regards to transportation, part of what we've done on a community level is bring mobile testing to communities. And then on a case-by-case basis for smaller batch testing events, as well as at times individual testing needs, we've been able to accommodate, but that's mostly been case-by-case. In regards to technological barriers, we tend to have at registration always someone available who speaks English or Spanish, at least, to be able to support someone with their registration if they want to do an on the site registration. And then we just have to kind of continue to keep, I mean, these things don't go away. They keep being the issues, and we will keep working on them. So we appreciate getting the feedback. Barriers experienced at the test site, access for the uninsured, and feeling unwelcomed. It does feel, as others have already said, that in this moment of people with resource returning to normal, that the uninsured and the underinsured are less protected than they were at the height of the emergency response. So we certainly have our work cut out for us to continue to drill down and make sure that uninsured and underinsured folks have access to both testing as well as treatment options. Issues of trust in the process. Yes, absolutely. We spent the first half of the pandemic telling people that PCR was the gold standard and that rapid antigen was meh. And now we are moving to a rapid centered strategy. I think the real place that I look forward to partnership is supporting people to utilize the rapid testing resource, which is actually awesome when it is used in the way that is meant to be used. So I think we need to empower people to have the information they need to understand how to use it well. I figure if every person on the planet can know 6 to 13 different kinds of iPhones, I think we can do this. So I hope we'll be in more conversation about that. And of course, also knowing when are the moments where you actually still need to turn to PCR. I think we can go to next slide. There is the I don't have COVID comment at the bottom of that slide. I think that is an ongoing place that we all just keep needing to work together on how to help people to not deny that COVID exists. I'm not sure I know what to say from a testing strategy on that one. Some of the other great comments that you provided to us were placing sites in communities where the most are impacted, locating testing deserts, being able to focus on particular geographies and zip codes. This has been a very important part of our testing strategy. My biggest concerns when I saw these comments was what do we need to do more to ensure that people know about the resource, to know that they can request the resource, and to know that we will that we have the capacity to respond. Right now, what we have in our testing network is a mix of stationary sites that are consistent sites in priority neighborhoods where people can know that they can go. We also have a mobile testing fleet, which does both events, pop-ups, and then also does response-driven testing for congregate living and work facilities. And at times, as I said before, has the capacity to do homebound visits. At times we have coordinated that with homebound backs, et cetera. So, Gary, I'll just speak to that just in the moment. We have certainly been considering how to do that. There are a number of avenues right now already in effect to track data on home testing. Obviously, it's a voluntary process where people would provide their results. We have not opted into that yet because we were concerned that the data would come back fairly skewed to those who have access and time to do that level of reporting. But I am really, I continue to be open. I continue to be in conversations with our clinical teams around whether there is a benefit to it that we would want to take on. Co-location of services. Yeah, it's a great strategy. We have been doing it. We do it with vaccination, community vax often. Some of the considerations that we take into account are, is the site large enough to be able to accommodate two very distinct people coming for services, one to get vaccinated, others who may be positive and seeking a confirmation of that. So we want to keep those workflows separate. And if it does not seem that the site can accommodate a large enough space for that, we usually send at-home kits to be passed out to people.
We've got about 3 minutes left.
Great, perfect. Confusion, we are always definitely wanting to partner with community orgs we have a great testing team and messaging team that work very hard to make messages accessible, but I think the county has been accused of being quite wordy and bodacious, and I don't think that's wrong. So it's always great to get the relevance of community messaging. I think we're hoping to be at more tables where we can create that messaging on a deeper level with you all. And then we're also trying to hold a middle way in regards to just hearing, as people said earlier in this meeting, just how exhausted everyone is, and not wanting to expect another role from communities if that feels like a stretch. Next slide, please. Yeah, so some of the things that we've been working on that I just wanted to highlight. Home tests are difficult to use. At this point, we have a pretty robust cache of at-home kits that we are trying to get out. Our testing sites will be distribution hubs for testing kits. What we found was, even though they are readily available, that people who were not able to necessarily buy them in advance and then be reimbursed, or people for whom asking the federal government for test kits that may not come for a month, or even for folks who cannot go to Walgreens and buy a $30 box. We wanted to make it accessible by providing them at all community testing sites. A person can go and get 2 kits, 2 tests per day, and if they need more, that'll be accommodated as well. And we're also looking at other kinds of PPE that we may be able to also co-locate, potentially K95 and N95 masks, etc. Yes, thank you. And actually, our door team is delivering kits that include masks and OTC kits. With every OTC kit that comes out, we developed a guidance card. This card goes with that kit, and what it provides is information about expired tests. That's one of the questions that comes up a lot. Expiration, can I still use this test? As well as what to do if you are positive. What are treatment options available to you? What are your isolation and quarantine guidance? As well as what are the recommendations. So there's also a link, there's QR codes and links on that card, including some instructional videos to how to use kits.
I just want to check in because we're done with our time for this. I think you actually did cover a lot of our strategies when you were talking about looking at the feedback.
Mm-hmm.
So I just wanted to take one or 2 minutes to see if anyone had comments. And we could even jump to the next page because that just had a few more themes on it, but I think you've covered really most of it. So the questions are, did we capture sort of the priority and the key issues that you lifted up in relationship to testing, and open it up to anyone who, see if we have any comments.
If I may.
Mm-hmm.
Similarities with regards to monkeypox, with regards to testing, with regards to vaccination, they're almost inseparable from COVID. And now that this messaging is being implemented, the strategies are being put to use, we should also include monkeypox. Data, not data, but information sharing with regards to community CBOs, also development of testing sites where there is the singular message of you can be tested for both at either this location and that location. And I think, as Dr. Rhodes has asked with regards to accessibility to the vaccines, and then also if there is testing, that there should be, it should be in multiple communities. I don't see why not, because we are spending a great deal of money and a great deal of effort in vaccinating, in messaging COVID. Right now, we can message COVID and monkeypox and other chronic diseases, but I think it would behoove us to get ahead of the curve in that regard.
Thanks, Gary. Yeah, we were just talking today about, in the same way that when COVID vaccine came out, a lot of people came to testing sites to say, can I get my vaccine here? So we were just talking at first here, just how do we help people to find the resources that they need around monkeypox, or what are the things that they can do, or the education that they need. And then I think you're right, where we look at making things accessible and available to people is a great idea.
Okay. Well, thank you. And what I do, I know we're a little short on time right now. Thank you so much, Vasi, for presenting and bringing all your expertise to this. We really appreciate it.
Great to be with you all.
Great. So at this point, well, we want to shift over to our vaccine strategy. And I know many of you know Sandy Galvez. She has been the head of our vaccine strategy for the last over a year now. And we have brought on a new staff person. So Sandy, actually, would you like to introduce Kayeb and then turn it over to him?
Thank you. Hi, everyone. As Julie said, we now have a new immunization director for our health department, Kayeb Manker, who I'll be passing it to in a sec. Kayeb will be heading up our immunization program, which is within our division of communicable disease. And at some point, not too far down the road, our COVID vaccine unit will be folding with our immunization unit. So Kayeb and I work together on developing the response to your feedback. So I'll be passing it to Kayeb. Kayeb, I'm here if you'd like me to cover any of these.
Great, and welcome, Kayeb.
Thank you so much, Sandy, and everyone. Once again, my name is Kayeb. I'm the new immunization director. So just want to make sure that I stay on track. So I want to go and directly jump into this slides to make sure that we are on track with time. So as part of the questions we have provided you in the previous meeting, one of the things that relating to vaccine, the question was what are the barriers around this community we serve as far as access to vaccine and equitable access to our community members, and how is that disproportionately impacting our community member by the COVID-19 infection. So most folks have different opinion, but we try to categorize it in different portions to see, and one of them has been physical access, the time when we are providing access to vaccine, something related to technology, transportations, and so forth. Can you take off the, can you say that again?
Sure, just see Kayeb.
Yeah.
Can you hear me?
Yeah, we can hear you. And
okay.
But
I don't see the slides
are not
now.
there.
Yeah. So yeah, I guess we can only do one or the other, I think.
Can you see the slides now?
Yes.
Okay, good. Another question, another suggestions for additional service that are needed, something like providing vaccines and boosters with other supports such as shingle vaccines and so forth. General safety for the vaccination side and education around the service we provide and so forth. Another issue that was brought up was communication, some of the message that's been sent out is a little confusing and it's not consistent. And there's a constant change that keeps happening and so forth. And then also the culturally appropriate support. I want to make sure that we are developing a strong relationship with the community we serve, and folks who are at the vaccination site are actually meet or can connect or have the client who's come to get vaccinated can relate to the folks who are providing the services and so forth. And also the system-wide challenge, different requirements, accessibility to insurance, and I think this also been mentioned in the previous presentation. Next slide. And then also there are some successes we've had in the past with the COVID vaccination effort, and also effort that's been implemented to serve the community better. And the items that have been mentioned in the last meeting were to have a diverse multicultural staff during this pod site, hearing, seeing trusted representative from the community, understanding what they're saying, what they're telling us as far as the vaccine goes, and hearing them and making sure that we follow their suggestions, and also merging COVID support with other diseases as mentioned earlier. That's for additional services at the pod. And then also engaging with trust leaders from the community. I mentioned it earlier, like, working closely with our community navigators, trusted community members, leaders, and so forth to get good feedback. And then also additional investment and partners, as far as training related stuff, and investing more community related work. Once again, also our location and registration, all that also have been a little bit of a challenge, and we've received good messages around that as well. Next slide. So another one that relates to vaccine is what are the potential impacts, as far as co-location for COVID vaccines with other vaccines like flu or other common vaccines we often provide to our community members. Often the co-location services have been mentioned, combined COVID with other diseases education, and offer more clinics around, providing more of a holistic support, really providing service to the clients, seeing the overall challenges and health issues for the client and providing that support and so forth. And then also assuring safety measures, making sure the area that we're providing support is safe, and as far as the medication the treatment we're providing is safe, giving enough ample information and education around that. And so forth. And then once November becomes available, it would be important to ensure communities have access to it. That is also, it goes back to making sure we have all the needed vaccines available for our community members, and also really looking at the community from the lens of equity and making sure that that is available for the community the same way how that would be available for other folks who have insurance or anything like that.
This is great. And I'm wondering if we can jump into strategies. We just have 2 minutes left for this section.
Sure. Let's go with the strategies. So after reviewing all these messages we received from you, the strategies we followed up on is, and obviously one of them is the theme around physical access, increasing our after-hour clinics, weekends, expanding home vaccinations, and so forth. And the strategy we are working towards is, and also co-locating vaccination clinics. Those are the themes we have, and the strategies we are moving forward with is obviously co-locate vaccine pods with other events, making sure those are readily available within the community, offering such as flu vaccines and shingles and so forth, and also including activities at the pod site or the clinics that are fun, that it would attract a community member to come and engage with us in some capacity, whether it is playing or really having a good discussion about the community and so forth. And including mobile pop-ups and making sure that because of the cost associated with the stationary pods, we want to increase a lot of mobile pop-ups so that when there is a need, we can just go and post a pop-up pod to serve the community. Next slide. Another theme we have around is engage trusted leaders for the community. I think this is one of the most important ones from what I see. And the other one, is there another one? Just put them all on the page. There you go. Yeah, perfect. Engaging with the community members, working with more outreach, education, vaccine support, working closely more with our door campaign, which they've been excellent, reaching out to the community we serve. And then also roundtable community navigators meetings and so forth. As far as the electronic barriers goes, that's another theme we looked at, and also that's always been a work in process, making sure we offer support for those people who have have low digital access, we have folks at the pod site supporting them in different capacity and guiding them in ways that they need it.
And let me just jump in, because electronic barriers, we do have a call line. People can call in and they will, they can schedule appointments through the call line directly. So if they can't do it through a web or a cell phone, we are available to do that. Great. Okay.
That's it. Or there's one more.
Go to the next slide.
Yeah.
And
then another in relation to vaccines, the theme we also have is, the confusing messages, constant change, and so forth. And then the current and historical racist practices, lack of trust. Those are very critical things and very important, and we are really actively involved to address those things, and we continue to do that. So which including communication with teams, social media, radios, news outlets, and so forth, and the health and racial equity training for the staff to make sure, not only we are serving the community, but also the staff that works with the community understands our community well as well. To continue to locate clinics in neighborhoods that were disproportionately impacted by this COVID, making sure we use data constantly and addressing that challenge. And community feedbacks and so forth to make sure that we address that. And also to engage the staff that reflects cultural communities being served, and making sure that we are working with the staff around that challenge. And as far as the system changes, different requirements, and the confusing messages that keeps coming up is something that we are continuing to develop and also working with you guys to support us. So I guess the question we'll want to end with is, as you are listening and working following up with this work we are doing, is just to kind of think of what Julie mentioned in the beginning, is to kind of think about if we are on track, if we missed anything, and also how you can contribute to this effort and capacities where you are able to, and so we can collaborate more. Thank you so much for having me.
Okay, thank you. And thank you, Kaya, for jumping in with both feet. Been here for all of 2 weeks, I think, maybe 2.5 weeks. So thank you for that. I saw a question in the chat, will we be continuing with the home vaccination? We will be continuing with home vaccination. Right now, there's some balancing acts that we're doing because of monkeypox, but we will definitely continue that program because we understand there are pockets all over Alameda County where people are not able to get out to vaccination sites. So, and let's see, is there any other questions? Some of the questions, if we don't have time for them, we'll get back to you. And what I'd just like to prompt, I think for the next group, we want to go into our community support. The intention here, the headlines in red are really a summary of the comments. You don't need to go through the comments. And what I'd like to do is just jump to the strategy so folks can see what we can do. So if you'd like to, you can just lift up as we go through that and then go into the next. So I'd like to introduce Joanne Luby and Drew Jasper, who've been working in our community support team. And this covers our call line and our working on test to treat strategies. So let me turn it over. I believe, Joanne, are you going to do this part? Or
I think it'll be me, Julie.
Drew. Okay, Drew, thank you.
And I might go a little bit faster just because I want to make sure we get your feedback. So one of the themes we heard was lack of community awareness about treatments. This has been a huge priority for us over the last 4 months, treatments in general. So we did form a small team of nurses that are doing outreach to newly positive cases who are age 50s and up in priority zip codes, primarily HPI 1 and 2s. We have been working to expand test to treat sites, particularly beyond OptumServe, to bring in more of our FQHCs to have that ability. And we are partnering with CDPH and some grant works to try to get that accomplished. Of course, our partners, all of you, and our community's resilience partners and navigators are essential to all of this. And then again, another plug for the community support hotline that people can call in multiple languages, and then they can try to link people to resources for COVID, for monkeypox, or to get them where they need help the most. Next slide, please. We heard other themes that language capacity for treatments options is an issue. Some groups are not even told about treatment options by their providers, and that pharmacies are not always accessible for marginalized communities, and other problems with them not accepting phone orders. Again, the inquiries call line has multiple languages. We have been working for 4 months now to try to find a solution for a telemedicine call line where a symptomatic case does not have to leave home if they have tests at home, and that they can get treatment prescribed to them while staying home. We met again last week with CDPH to really stress that this is a huge equity need, not just for Alameda County, but statewide, countrywide. And we're continuing to pursue that in multiple different directions. Work with provider groups to increase awareness of treatment availability and options. We've been aware that not all prescribers have the same level of comfort or most up-to-date information. We recognized even with Evusheld, which is the only prophylactic for those who are immunocompromised or immunosuppressed, that it wasn't getting utilized. So Dr. Moss and our clinician team sent out a health advisory last week, and that's something that we continue to discuss. And then as far as pharmacies not accepting phone orders, you can call our hotline as well to report that, or contact us to report pharmacies that are not doing that. We can report that to CDPH, and they can work with CVS or Walgreens Corporate if they're not taking telephone orders for prescription. And I think that was it. I do apologize for speaking fast, but I think we really wanted to make sure that we're heading in the right directions or where our gaps might be.
So yeah, I think, do we have a few minutes left, Lauren or Nestor or Gary, Greg, to get some feedback or get people's questions or thoughts or concerns?
That's not yeah.
I would say that we have at least a couple minutes.
Okay.
Yeah.
So we would welcome anyone's thoughts about this. Are we on track? Do you feel like we captured what the feedback that you've given us and what you see as most important?
I see Bruce's hand. I wasn't sure if that was a hand raised or not.
Okay, Bruce.
Well, I've seen and heard in most of these discussions for quite a few of these meetings, and I'm not trying to be the elephant in the room. I'm pretty sure to be that. Confusion over messages. This seems to be a theme. Constant change, theme. Unified messages, theme. And who are not telling what, when, etc. I know you're all trying the best. I understand how hard this is being a pediatrician and dealing with small children and parents who sometimes have minds that are not as malleable as you would like them to be. But there's a continuity that I just don't hear has been happening for 4 to 5 months while we've been dealing with this. And wondering if there's a separate team that works with, okay, this is what the thing is, versus a team works together and then doesn't contact or communicate with another team to make sure that these don't happen. When you come with all different languages, yes, and beliefs, there definitely can be, but on the general information that's going out, that should be pretty standard, and saying something to the effect, we understand that this was where things were, but as with all problems with illnesses, etc., or diseases, things do change. And this is why it might not be the same information. How do you feel about that? Are you upset, or can you understand and work with us, unfortunately, with these new pieces of information that are there? You don't have a lot of time to do the things that you need to do as far as talking with things. You have to go with this person, then the next person, then the next person. But there are specialists I know who work within the health department who specialize in how do you talk to people and get messages through, even if the messages are changing. You have an awful lot of people in your department doing an awful lot of things. And again, it comes back to messaging.
Thank you. And clearly that's a huge theme throughout. We've been hearing it for a long time. And there's a number of things. I think people have lifted up community-driven messages and community-driven messaging strategies. I think there's certain pieces of the conflicting message that we can spearhead from the health department's perspective, and that's working with providers. Because, you know, we've become aware not all providers are aware like of the different treatment options or who's eligible. And that's an area where we are meeting with some in different health roundtables. But it's something we could work on to be more consistent. I think there's some other areas of messaging. And I know, Austin, you're here. I don't know if you wanted to say a word or two, or if other people had comments from the CAG before we speak up again. So Austin, did you want to just make a comment or two about this? Because I know it's something you've been working with.
Yes. Good evening, everyone. Austin Wingate with the new unit, the Health Promotion and Community Partnerships Unit. Yes, we've heard this from a number of CBO partners. We call them Community Resilience Partners because their work with addressing COVID-19 and hard to hit communities. This has come up a number of times in terms of really wanting clear and consistent communication. And one of the things that I tried with the Community Resilience Partners is really boiling down some of the talking points that they have access to and really highlighting the things that need to be shared with community members, almost like, okay, really giving people the information about where we are today and the why behind it. And for that particular group, it really seemed to help make things clear, consistent. So I am in communication with the PIO, the Public Information Officer, in thinking about the talking points that are shared, and if there's some way of perhaps distilling or breaking down those talking points more so that it's more clear and consistent across the board.
Now, what has worked the best, and over how many times does that one work better than the other one? Yeah, it's parenting. That's what you all are, parents, trying to get your children to understand what you're going to do before you do it to them. And get their acceptance, because they're big children. They're not ones who say, no, you can't do it. And then you hold on to them and give them a shot. Or
Yeah, we definitely realize that this, I mean, we're grateful for the partnership and all the work that you and the Community Resilient Partners who aren't on this call are doing. And we see this as a key partnership in need in order to really address COVID-19 in the community. So we definitely don't take your feedback for granted. And we try to implement it as much as we can when we can.
And I also want to lift up, this is such an important point that we are part of a public health system, as I see it, that includes all our community partners. So there's what the department can do, but there's also a lot of you have a lot of influence in your communities. And I think the more we can work together and create those messages, or as Austin was doing, trying to boil them down and simplify them. But if we can work together and all take some part of some responsibility for getting these out, that'll be really helpful. I think it's the only way we're going to make a dent in this particular, it's a real challenge because messages come from so many different sources here, but thank you for that. And I do want to say, I think what we'd like to do is we will send out the information that we put out, and we do want to get people's feedback. I know we're at the end of the time right now, so I'm going to step back and turn it back to you, Greg and Nestor.
Thank you all so much for a really important conversation this evening. We know that everybody's putting in heart and soul into keeping our communities healthy wherever you are and however you interact with the system. Welcome to our new folks. Kaib, and who was the other person? It was
Drew and Joanne.
Yes, and really great to have you all part of this work. And again, thank you for your time. If you have any additional feedback, you know how to get in touch with us. Please, when Julie sends this out, if you got any additional comments on the refresh, please do that. And please stay healthy, please stay safe, and try to get out here and enjoy some of this nice weather when you can. All right, you all have a great evening, and we'll see you the next time.
Okay.
And Dr. Dunn, that's who I was forgetting, Dr. Dunn. Thank you.
Yeah.
Bye, everybody.
Bye now.